I'm Dr. Thomas Rocchio, and the podcast that we're performing today is part of a continuation of PA foot and ankles educational seminars that we give to the public and to our patients. So if you missed the earlier ones, we had three previous really interesting ones that included sports injuries and general foot care as some of the topics. So we can always go back on YouTube and find those. Today, I wanted to talk about not just wound care, but kind of a whole area of foot and ankle surgical practice that is such a necessary area, and that is limb preservation. When we have patients come into the office, many times, and frustratingly enough, um, we have situations where patients will have an open wound on their foot, and because you live your whole life getting injured, having a cut, allowing that to heal through natural neosporin treatments and cleaning it off with sudsy water, we have this built-in desire to heal ourselves. And what can be a concern is when that comes in a situation or a background uh, with comorbidities such as diabetes and when it affects your foot. One of the scariest stats that I ever heard, and it has nothing to do with this talk, is the first symptom, the number one symptom for heart disease. And somebody asked me, what is that? And I said, I don't know. What is it? Chest pain? And they said, no, sudden death. And it was very eye-opening because many times the first time a patient of ours that has a severe comorbidity gets a wound, that can be the episode that causes the toe amputation or the loss of leg. So it is so important to have education like this, where we can get out there and get ahead of having that first episode, and or if you're out there and you have a wound now that you're treating yourself, maybe have a doctor take a look at it. And it's important too that if you're looking at this in Alaska or you're looking at it in Macungie, Pennsylvania, where you can readily come and see me, that you get out to your local specialist and have that wound looked at. Uh, I'm going to try and keep my thoughts together because there's so much information and so many directions that we can take this podcast. When we look at limb preservation, and it used to be called limb salvage, uh, we look at really a team. And when wound healing centers came about, the first thing that they sold this idea to the public was that you would have all of these specialists together. Well, with the way logistics works and the way medicine works, very rarely do you walk into a room and you have five specialists standing over you unless you're inside a hospital system or in a hospital bed. The best way to have this accomplished is to keep your primary care physician very active, have them act as a gatekeeper, and have your specialists that deal with problems that could come about from wounds, such as your foot and ankle surgeon, that would be my position, your vascular surgeon, because circulation is so important to evaluate. We have endocrinologists to manage conditions such as diabetes. And there are many ancillary personnel that I didn't mention that are so important. And believe it or not, plastic surgery we work very close with, as well as other wound care specialists and that would deal with taking care of a patient's individual needs with limb preservation in mind. Um, when we look at chronic wounds or we look at acute wounds, one of the most staggering stats is that most amputations are preceded by an ulceration. If we can identify deformity or identify conditions that predispose patients to develop an ulceration, and we can get out ahead of that, and we can utilize programs such as the diabetic shoe program that offers a custom molded insert to diffuse pressures, we can eliminate ulcerations, we can mitigate the presentation of those ulcerations. But if we could also identify those ulcerations quickly, we can have patients not have the amputations that they were hurtling towards before this education started. One of the most impressive studies from a podiatrist point of view, which I am, is a study that took one single Indian reservation that had in a single year 2,000 amputations secondary to diabetes. They introduced a single podiatrist to that reservation, and the following year they had no amputations. That's a staggering stat, and it was uh, so staggering, so deafening that every Indian reservation now has podiatrists on full-time staff. Early intervention, I can't say enough how early intervention dramatically improves limb salvage. Uh, when we look at patients that I see, I have the patients all the time that come in for uh, evaluation of a wound, or they're coming in for something else that maybe is a simple follow-up, and I'll say, "Well, you have a wound on your foot. What's happening here?" Oh yeah, the dog uh, knocked something over and I stepped on it, or I had this scratch from my cat, or I had something I stepped on. I'm going to heal that myself. It's doing pretty good. Those are the scary times, and we catch those early because those are the ones that'll jump up and bite you. Uh, I think that's one of the most frustrating things in my profession is just getting this education out there. So when we look at having a wound, there's a normal way of healing this wound that patients that don't have comorbidities such as peripheral arterial disease and diabetes will heal this wound. Uh, when you first get the wound, let's say it's a traumatic wound, and we'll say that I am holding a knife blade and I accidentally take a little scoop out of my arm. Well, there's a bleeding phase, and you start to bleed, and then your body starts to perform something called hemostasis. Platelets will congregate in that area, and those platelets will then break down and they'll release something called platelet-derived growth factor. And that's kind of the magic in your body that starts to signal these healing pathways. That promotes something that's very important called the inflammation stage and the inflammation phase, excuse me, and that will call in cells that come and fight bacteria and that chew up the damaged tissue. And from there, there's a natural signal from your body that that phase is done, and you start this proliferation phase or healing phase where you start to see growth of new blood vessels, and you start to bring in granulation tissue that fills that damaged tissue in, and then you start to have the skin cover before you start to go into the remodeling phase. If we have patients with comorbidities, like most of my patients have, such as diabetes, there's a cellular dysfunction. Uh, there is a lack of the ability to signal these next healing phases. So having a wound professional, such as myself, evaluate that patient and take them through healing, we can identify a lot quicker these cellular dysfunctions that might not just be infection, which is a whole nother category. There is a very real presentation in all wounds called biofilm. Bacteria that lives in our skin and lives all over our body can become a problem. It can lay down this product that protects the bacteria from topical antimicrobial types of gels or neosporin. So you have something called biofilm that sits on top of your ulceration. You can't see it in the naked eye. The only time you can really see it in the human body is with plaque on your teeth. That's a type of biofilm. So you have the situation where this biofilm is chronically irritating because it's bacteria. So you're prolonging and prolonging sometimes for indefinitely the inflammatory phase where your body is calling these macrophages and cells to keep chewing up and fighting bacteria, but you're never really getting over the hump and healing. What else that bacteria and biofilm does is it fights for nutrients that your body needs to heal, like oxygen. So the last thing it does is it kind of acts like a reservoir of bacteria where it keeps seeding new bacteria. So if at any point it gets ahead of your immune system, that's when you can get infected. So you not only have the length of time prolonged indefinitely from biofilm, but also chronic reigning bacteria that can get you sick. And just one of the other angles that a good wound care professional will begin to perform what we call debridement. If you're familiar with wounds or have family members that have had wounds, then you probably have seen a debridement. And I always have, probably weekly, have patients that say to me, "Oh, you're going to make my wound bigger again. Here he goes again with that blade." Removing the non-viable tissue, removing the biofilm, and telling your body, "Hey, you're not healed yet." There's another angle called senescent cells, where the cells of the body are just lying dormant. You kind of getting rid of them and waking up that wound and getting it back into that inflammatory phase so we can start the healing again. There used to be studies on different wound products, and companies would have to do these studies to get approval. If you look at the studies from the 90s, there was a category of patients that got the product and a category of patients that didn't get the product X. And they used to say these patients in got debrided and these other patients didn't get debrided or cleaned up with the blade. What we were finding with the studies is it didn't matter whether you got a product or no product. The patients that got the debridement healed faster than any other category of patients that didn't get the debridement. It became such a known standard of care that you're no longer allowed to perform studies that don't include debridement. It's considered cruel and unusual. So that's another reason that a wound care professional and weekly visits are so important. Uh, so we know why wound care matters because these wounds lead directly to infection and lead directly to amputation. But are all the wounds the same? Are all the wounds that we see in our patients the same? And obviously, the answer to that is no. There are different reasons why patients will have ulcerations. When we look at common ulcerations, I'd say the most common that I see are neuropathic ulcerations, but one form of ulceration that we do see often, and they're seen tremendously in high volumes at wound healing centers, are venous leg ulcerations. If you've ever seen a person out on the street that looks like their leg has this permanent tan or a dark almost tattooed ring of darker tissue. If they're light skinned and they have this like brown almost looking tattoo, that's called hemosiderin deposits. Uh, Edema, swelling with blood, either a lymph fluid with venous blood in the skin. Iron is deposited in the skin because red blood cells have iron. They get left out in the skin, and over time they get broken down, and it creates these changes. It could also cause changes in the skin that make it very compromised. There's an expression called peau d'orange or orange peel skin. And this is a highly compromised skin structure that you see in patients with venous disease. These wounds can be very shallow. They can be punched out looking. They're very painful. I'll always remember being in school and getting the question wrong because I put that venous leg wounds were painful, and the teacher said, no, they're not painful. And I had already experienced through patients and through family members this being a very painful process. So these venous leg wounds are certainly painful. And I think that I have a few patients that might be listening right now that would say, yeah, I agree, they are painful. We see these around the ankle area, and they're very difficult to heal. One of the number one things that needs to be done is not only the debridement and not only the managing the bacteria, but what also needs to be done is managing fluid. When you have a venous leg wound, they can be very much an active draining area. And what's wrong with active drainage, if we don't manage that drainage and get it away from the patient's skin, that can cause a dermatitis and further breakdown. Venous leg wounds were first really remembered by me because I remember seeing a patient who had a small wound, and the next week it was almost this man's entire leg. And a lot of that can due to the rapid degradation of the skin around these venous leg wounds. But the number one thing that needs to be done is not only management by the primary care physician, making sure these patients don't have congestive heart failure, but we need to compress those leg wounds. If you have, or your family member that's on this call has venous leg wounds and they resist compression, they are limiting their ability to heal. or if they want to have their leg hanging down and having that swelling continue without compressing it, it makes it very difficult to get successful healing. Um, what when you have venous leg disease, we also need to make sure that you don't also have arterial disease. So one of the most important referrals for when I have a patient with venous leg disease right away, not only do I want to make sure they're with their primary care physician and they're being managed by all the professionals that would take care of them if they have heart condition, but a vascular surgeon. In our profession, we work so, in my practice especially, we work so close with the vascular specialists that work at the nearby hospital. They're terrific. They understand our patients and they understand our patients' needs. And these vascular specialists can actually evaluate patients for arterial disease. And I think a lot of people on the call would know that vascular surgeons can increase blood flow with certain procedures, but you might not know that they could also do procedures that help reduce the swelling from sick veins. And that's something that a patient, I think, always should be evaluated for, especially with venous leg disease. And we're going to kind of talk about some other things too that the vascular specialists will come in handy for and are really a valuable piece. If there is too much drainage, we need to use products to manage that drainage, to wick that away from the skin. We don't want a wet draining wound to stay wet and draining. And it's just like we don't want a dried up wound to stay dry. We want to add moisture in a safe antibacterial way to a dry wound and get moisture away from a wet wound. Many times, if you're my patient, you might have heard me say this. I'll always say, it's not what we put on, it's what we take off. And I'm saying that a lot to the patients when I'm doing my debridement and cleaning that material away. But I'm also talking about pressure on the lower extremity for my neuropathy patients or my pressure wound patients that are neuropathic ulcerations. Yeah, let's talk about those neuropathic patients. A lot of the times people think that neuropathy only comes from diabetes. We can have neuropathy from unknown sources. We could have neuropathy from damage to your spinal column. You could have something called radiculopathy, where you have damage in your back that causes pains and also neuropathies in your lower extremity. You can have conditions as recently as this year. I've had one of my youngest neuropathic patients that to have a very serious complication from neuropathy, and that was an injury at birth that was addressed. This patient had a pretty uneventful life until age 15, where an injury uh, brought on a neuropathic response that we see only in patients that have numbness and have neuropathy. The reason diabetes gets such a spotlight when you hear about neuropathy is that all diabetics have neuropathy. When you have diabetes, it's not, oh, maybe someday I'll develop neuropathy. You have neuropathy. It's just at what level and how does that affect you? And normally we'll see first the vibration sensation start to dampen. So I'll show my patients in the office. I'll have a tuning fork. I'll use a vibration, but it's so important to assess that level of neuropathy, even if it's just at first to hear it for the first time and to have it as an understanding that this represents a very real concern that we want to make sure that we don't have these types of developments in the future of wounds. When we have neuropathic ulcerations, it's very difficult. If I have a patient that really can't manage crutches, but they have a wound from numbness and deformity on the bottom of their right foot, I'm going to need that patient to be off of that foot. So we have different types of devices, such as kneeling walkers. They're a little scooter that you might have seen patients utilizing that will allow this patient to keep the weight off the bottom of their foot. At the same time, we have to manage infection. We have to be making sure that we are debriding that ulceration of that callus tissue, that necrotic tissue, waking it up from that chronic inflammatory phase and starting the healing process again and keep bacteria out of there. So all of these things have to be going on at the same time. What is very troubling is that patients that can't stay off their foot or will feel as though, well, I'm only walking on my foot through some of the day, have such chronic trauma from walking on this numb, deformed foot on this ulceration that they don't heal these wounds and they get frustrated. They say, Doc, I've been coming to you for a month. The wound's not getting better. But every time they walk out of my office, I might see them walk to their car and I can only be with you for the 30 minutes in my office. I can't take a patient home and see if they're keeping their weight off their foot. So there has to be a good dialogue and some honesty, just like the venous leg ulcers need that compression that some patients are uncomfortable with because it could be painful. It is very difficult for neuropathic patients to stay off their foot, which is so vital in healing. Another thing is if you have deformity, it might not be just good enough to stay off your foot until the wound heals, because once you begin to walk again, that deformity is going to be present. It's going to cause pressures. You're going to get a blister. You're going to get that ulceration again. And it's going to be so frustrating for you because you did the right thing. You stayed off your foot. That's why a dialogue with a foot and ankle surgeon like myself can actually look at taking a deformity and surgically offloading this. There's no more greater an example than there is with a condition called Charcot. I'm not going to get too much into that now. We'll revisit that in a little bit. Uh, when we look at diabetic or neuropathic non-diabetic ulcerations, many times this is not something that is because of poor circulation. And while venous disease is because of poor veins, many times it's not really because of poor artery flow, even though you can always have arterial disease added into any of these other conditions. When we have a class of wounds that comes from arterial disease, this could be a very tricky and a very difficult situation because with lack of blood flow, whether it's from the main arteries that have names when you open a anatomic textbook, or whether it's from microvasculature or death from the smallest level, think of those small capillaries in the toes. This is very difficult because I can't take a patient that has real severe end stage peripheral arterial disease or ischemic limb disease and just debride that wound because I won't create bleeding tissue. I'll create further tissue that is cut away that the body doesn't have enough circulation to heal, so the wound could actually get bigger. That's where immediate referral to our vascular specialists. Um, I'll mention the vascular specialists that work local to me at a hospital called St. Luke's Hospital. Amazing group, terrific group. They're enacting and they have been personally with our group doing this for a while, but they will get patients in, not through emergency room. These aren't patients that are infected that need to be admitted, but they'll get patients in quickly, knowing that they need to have very valuable studies performed not months from now, but days from now. And there's a very nice program called LEAP, the lower extremity amputation prevention, that we can simply contact and say, hey, I have a patient that is a LEAP candidate, and they will get this patient in quickly. They do amazing work and they will evaluate that patient to see if they have an option for revascularization. And I'm not a vascular surgeon. I won't speak to all the different options that are out there. Um, but I want to kind of put a bookmark in something. There are sometimes where the vascular specialist will say to me, they'll say, Dr. Rocchio, we don't have any viable surgical intervention that can increase the microvasculature at the area of that ulcer. So this patient is at imminent risk for gangrene, needing to have a removal of that lower extremity back to the level where the circulation is recorded on these studies. When I was working up till about 12 years ago, I used to always make the statement, if you have an ulceration, with the exception of one that has no circulation, I can do extraordinary things to potentially save your limb. have a tool in my toolbox that I'm incredibly excited about. A surgical procedure that was first discovered kind of as a side benefit when patients were receiving limb lengthenings in Kurgan, Russia by Gavril Elizarov, a famous Russian orthopedic surgeon. And what Dr. Elizarov noticed, he said, boy, when we do these limb lengthenings up by the shin, at the up by the knee area, I'm finding a tremendous circulation increase that is healing problems that are down in the foot. So Dr. Lizaroff, this was in the 60s and 70s. Dr. Lizaroff, before his retirement and eventually passed away, he did a study on canines in 1989, and he created a trauma to the shin bone, and with an external fixator, he slowly pulled bone away and slowly put that bone back over the course of several weeks. And doing studies on these dogs, he found that the body had an amazing physiologic response that he kind of coined the law of tension stress, where the body responds to gradual stress. And what he found was growth of microvasculature, a tremendous increase in the body's production of growth factors that directly aid in healing, not only bone healing, but also soft tissue healing. So in 1999 in China, a group of orthopedic surgeons got together and started to do these experiments with these procedures on patients that were supposed to get amputations, and they were getting tremendous benefit. It took until about 2020 before that data came to the United States, and it was originally presented about 5 years ago at the Orthopedic Academy meeting that I was at. And they showed this. Orthopedic Academy, if you're not done with your lecture on time, they shut your microphone off. This lecture went 1 hour over. Nobody turned any microphone off. It was amazing. People were floored. And of course, we needed to verify. And over the past 4 years, I've been performing this procedure on select patients. And to date, we have all good responses from this procedure. And it is something that is incredibly exciting. And I hope only to see more and more of this. From when I first started to perform this, I was using products that were already out there, and I would just change some of the building structures, kind of like a erector set, and I would get to accomplish this task with pre-existing products. We now have 4 orthopedic companies that have designed their own products specifically for this treatment. This is being adopted in the United States, and everything is showing that the Chinese data and the Russian data before that is correct. So there's hope for people with staring down leg amputations with peripheral arterial disease, and that's probably the one thing that I'm most excited about. Um, when we look at other types of ulcerations, the big three that we talked about, neuropathic, the ones from peripheral arterial disease, and the ones from venous disease, we have also those ulcerations, and it can be any of those categories that are also infected that have bone infection. Um, there is an unfortunate reality that I still think exists that if you get bone infection and it's visible on X-ray, that bone is not viable. To see bone infection on X-ray, 70% of the bone needs to be eroded away. That is not a bone that is going to be recoverable. Uh, and then the treatment for that is to remove that bone and usually the soft tissue around it. So our goal is to lessen the effect of infection in the soft tissue and avoid it from getting to the bone if we can. When we need to decide whether this bone is infected or not, that's also some gray area. Uh, we always were taught that the standard of care was a bone biopsy, taking a piece of the bone and sending it to the lab. I still rely on that heavily. I also rely on MRI. We also use bone scan as well. I talked about neuropathic breakdown called Charcot. That is a foot that becomes red hot and swollen. A lot of times you look at that quickly and it's hard to say that's not infection. That is actually Charcot, but it is so important to know that. And one of the things that we do to differentiate, other than our clinical presentation and our clinical gut feeling that this is not an infection, is we can perform a bone scan that can differentiate whether this is a Charcot or an infection in the bone. So I keep talking about Charcot, and I mentioned Charcot. Why is Charcot so important when we're talking about wound care? This foot that I talk about that we see with neuropathic patients, and that's all diabetics, but also all neuropathic patients, we theorize that this comes from a trauma. And studies have really shown that it's the trauma that's more important in having the body have this response that is a flushing of the area, many times in the middle of the foot, where we have a washing away of calcium and a breakdown of ligaments. And due to the forces of the Achilles tendon pulling up on your heel and weight bearing pushing down on the foot, we see a crushed of the middle of the foot called a rocker bottom. The process of Charcot would then calm down, and the patient will have a kind of a fusion in that area, now fused in a deformed position. I personally would advocate that if you have active Charcot, you would see a specialist like me immediately, not just to definitively say, yeah, you have Charcot, but actually to arrest the Charcot immediately and to mitigate the damage that's going to be caused by letting that Charcot run its course, or God forbid, walking on that. So I know I'm kind of getting in the weeds here, but why is Charcot so important when it comes to wound care? You now have a deformed foot, and you have a foot that is bearing weight no longer on the ball of the foot and the heel, but you're bearing weight on the middle of the foot on these cube-shaped bones that have dropped down, and you're bearing weight there. And you have ulceration breakdown, you have connection with bone, you have bone infection, and now you have a foot that is at very large risk of amputation. Some of the early intervention that I've done with Charcot foot, just as an aside, started in 2003. This is still not in literature today. It's still not considered standard of care today, though amongst the Charcot specialists, it's being widely adopted. I had a patient in 2003 with an active Charcot. I put them in this traction device that I mentioned that Elizaroff had done so much work in the 60s and 70s with. When I put the patient in this traction device, it immediately arrested the Charcot. The redness went away in the OR. The patient's edema went down. The bones that looked like they were all fractured came back into perfect position because the ligaments were still attached. So a fractured bone pulled back out to length had the ligaments put the bone back in position where it can be held in this device, where that patient had a chance to have a foot that still looked like a foot afterwards without that ulceration presentation. It's a different lecture, so we won't go too much into that. Uh, when we look at just deformities in general, not just Charcot deformities or these extreme deformities that we see with our diabetic and neuropathic patients, what about other deformities such as hammer toes or bunions, or things that we see every day? And if we go to the beach, we'll see it on 100 patients. Uh, with a patient that has full sensation and a patient that has full circulation, these can still cause wounds. They can still cause issues. But you add a patient that has peripheral arterial disease or is aging and their circulation is becoming less optimal, or they have neuropathy, and simple hammer toe can be a limb-threatening or life-threatening presentation. These are the types of deformities that I would not ignore, especially if it's causing a recurrent ulceration. I had a patient that I discussed Charcot reconstructive surgery with 3 years ago. We had healed the wound. I said, it's now time. You're a limb-threatening position. The patient wasn't ready for the surgical procedure, and I understand it's not a fun piece of news to get. Disappeared from my practice, returned just several weeks ago. In his medical record is 6 episodes of septicemia where they had an open wound from that deformity that brought them to the hospital, that gave them IV antibiotics, did OR debridements, healed the wound, only to happen 5 more times before they eventually came back with an open wound again. And I discussed with them wound healing and reconstructive surgery. Uh, Deformity is a big issue when it comes to neuropathic patients too. I mean, especially. It's not just amputations and big surgeries. Hammer toe surgery, it can be as simple as in the office, making a small cut under the toe and taking that tendon that pulls the toe down, that's giving you that tip of the toe ulcer, and straightening that out. Sometimes I don't even need to put a stitch, but something simple like that will save a toe. If you have peripheral arterial disease, we'll obviously monitor that. But if I feel like you can heal that, it can save a toe. It could save all the toes because you may have infection that causes bigger issue, or other toes start to get involved, and you can even save a leg if you're having infection or circulatory issues. So I think when we start to look at what you need for wound care, a lot of times it's a circle of the wagon type of event. If you've had a wound for a long period of time and you're not getting better, sit back and evaluate. Have a different doctor look at it. It doesn't mean your first doctor is wrong. It might be that you're not hearing exactly what that first doctor's saying, or you're not thinking of it correctly, or that doctor might not be giving you the education that you need to kind of get that wound managed in your mind so that you can manage it on your body. Sharp debridement, we need to excise that ulceration. Enzymatic debridement, we have products out there that if you're having too much pain, or you have a wound that has so much fibrous tissue, we have products that go on every day that are enzymatic debriders, so they painlessly can chew away that bad tissue and leave the good tissue. Uh, we also have hospital systems that have products like hyperbaric oxygen. If you have peripheral arterial disease and we can increase your oxygen level, there are tests we can do to see, a challenge to see if that'll help you. And if you're a candidate for that, that's something that increased oxygen will help you tremendously. And that's why it's always nice to have these hospital systems around. We have skin graft substitutes that are ample in the United States. They can help patients with a cellular dysfunction get these living cells to help them start to complete that pathway and break them from this inflammatory pathway that has the body just continually chewing up and causing this perpetual ulceration. So, a wound care professional that understands the different options that are out there can check with your insurance and see if that's something that is approved as well. Uh, from growth factors to more appropriate offloading to surgical offloading to hyperbaric oxygen to negative pressure where they can put a foam over your ulcer and cover it with inclusive dressing and use that same stress tension principle I keep bringing up from the original Elizaroff thought and draw on that granulation tissue to help close voids and take drainage away. There are so many great products out there, but remember, it's not what we put on there; it's what we take off, and that's one of my takeaways. Um, I do want to give a shout out to a doctor that uh, inspired me greatly, and he sent a patient to me about 12 years ago, and I started to talk about this earlier ahead of when I was going to talk about it. But Dr. Wesley Cozen, an infectious disease doctor that practiced in the Easton Palmer area, incredibly progressive, was a specialist not only in wound care, but also did a lot of work with Lyme disease, which this area had a ton of. Uh, but he sent me a patient, and I'll always remember he said to the lady, she had dry gangrene and she was with her husband and she was elderly. And he said, I don't think there's much we can do, but if someone maybe has an idea, it would be this guy. And I, unfortunately, at that time, didn't have the uh, that tool that I talk about in my toolbox. That's called transverse tibial transport, where we put this small device, make a little window in the shin, pull it away and put it back, and that grows microvasculature to the limb, which is amazing. It increases growth factors, increases warmth to the area, and increases blood flow to the area. And this has all been shown with studies. But I'll always remember telling that patient, If it was an infection, I can help. If it was something where you had a deformity, I can help. But without circulation and without vascular able to do more, I can't do much. There are also amazing new vascular procedures that are coming out. There are procedures that kind of hijack your lymphatic system and can have blood flow through your lymphatic system that my jury's still out, but I've heard some good things about. And there's also new bypass techniques, and the doctors that we work with in vascular are on top of all of these specialties. They are appropriately aggressive with their skill interventionally and also with open surgical procedures. So I'm very happy and privileged to be able to work with those doctors. Uh, I think I've talked a lot, and I don't have a moderator to kind of rein me in. So I'm kind of just going at it. I'm looking at the time, and it looks like I've talked for about 40 minutes. But I feel that I've laid out what I can offer as a wound care specialist and what I lecture on around the country and around the world with advanced limb preservation. I purposefully use this background. Each of these devices is an Elizarov, the Russian designed circular external fixation frame, and many of those have been used to reconstruct those Charcot patients and some of them have been used for pediatric deformities and traumatic deformities. But it is an amazing tool that certainly you wouldn't go sign up to wear, but if you needed one, you'd be very happy that something like that exists. I'm willing to open up for some questions. Jared, if you're there, you can uh, you can have anybody that wants to ask a question start to ask. That'd be fine.
Yeah, of course. Well, on behalf of everyone at PA Foot and Ankle Associates, we would like to thank Dr. Rocchio for sharing his expertise and providing valuable insight into what are the latest advances in wound care and limb salvage. We hope today's presentation has highlighted the importance of early intervention and the innovative treatment options available to help patients preserve mobility. We want to thank you all for taking the time to join us this afternoon. We appreciate your participation and your commitment to advancing patient care. And like Dr. Rocchio said, at this time, we would be happy to open the floor for any questions that you may have. If you are able to unmute yourself, you can do so. If not, just let me know in the chat and I can do that for you.
Yeah, and while people are waiting, I always knew that it was going to be happen, and it happens every time I do one of these talks. I'm like, oh, I should have talked more about this as well. In the background and things that you can do yourself, I can't uh, overemphasize how important nutrition is. When we have patients that come to see us for wound care, we always will emphasize nutrition, and I will prescribe a drink mix that kind of gives you everything you need to optimize your healing. There are products that you can purchase over the counter. There's a product called Juven that was first geared towards nutrition and with diabetics, but also helps with wound healing. But the product that we prescribe out of the office is tremendous, and I'm very happy to have these new additions to our treatment protocol that can get patients the best chance to heal these wounds and to mitigate problems down the road.
All right, looks like no questions. So thank you again for being with us today, everyone. We appreciate your support and look forward to seeing you at our next monthly webinar. We hope you have a wonderful afternoon. Stay well and find us on social media for some upcoming uh, engagement with doctor advice and reels as well.
All right. Thanks, Jared.
Of course.